Well, hello everybody. Good evening. After a long, wet, cold day, I'm giving up some solid snuggle time in front of the TV. So thank you for coming tonight. My name is Desiree White. I am the lead provider at the Foster Adoption Clinic in Tacoma, soon to be Puyallup. We'll be moving soon. I recognize a couple of names on the list today, so hopefully I already know you. If not, I've been blessed to be able to give several different topics to your group, and hopefully, this is one that will be important to you. So, as we're talking today, I am not able to see you or the chat. So, if you do have any questions or any thoughts, go ahead and put them in the chat, and Luann will be able to monitor that so I can answer your questions as we get to them. So, here we go. I usually start these talks by telling you what I'm not, which is kind of a goofy way to instill trust and confidence in everyone. But I am not a urologist, and we are going to be talking about bedwetting. I am not a gastroenterologist, and we are going to be talking about constipation. And I am not an occupational therapist. We're going to be talking a lot about social emotional development. But I am a nurse practitioner with 25 years in childhood trauma, and I'm an adoptive mom myself. And these are conversations that I have had with my own children's pediatrician. These are conversations that I have almost on a daily basis with patients that come into our clinic. And I am a firm believer that if trauma can cause damage to our chemistry, then healing and education can do the opposite. So I'm thankful that you are all in the same frame of mind. We are also going to be discussing children greater than 3 years old. There is a different kind of approach to constipation for younger kids. We won't be talking about that today. And I will be making some personal product recommendations. I do not have any investment in these products. I do not get any kickbacks. These are just things that have worked well for me and for my patients, and they may be something that will work well for you. So the things that we're going to be talking about today is we're going to go through trauma and attachment and how it impacts bedwetting and constipation. We're going to be talking quite a bit about interoception, a little bit about proprioception. We are going to go through some anatomy. There is a picture, side view of some male anatomy if you have any little ones that are with you today, and you don't want to field any questions. Hopefully I'll remember to warn you ahead of time that it's coming. We're going to be going through tips and tricks of bedwetting and constipation, when to refer, how insurance plays a part in this. Of course, if there's anyone in the group that's just not going to be able to sleep tonight unless they have some references that they can check, that'll be available to you, and then we'll field some questions. So, attachment, it always comes back to attachment, right? So, when a baby is first born, the first thing they do is scream, right? What they are communicating is, I was nice and warm and well fed and comfortable, and now I'm not, right? I am now dysregulated. I am cold, I am wet, I am hungry. Somebody fix this. And the first thing that we do as safe adults is we bring that child to our chest, we calm them down, we lower our voice, we meet all of their needs, we provide their food, we change their pants, we make sure that they're warm. And we repeat this process over and over and over again through a child's early childhood. To teach them how to become internally regulated. That internal regulation is dependent on someone else externally to meet that need until they can do that on their own. As a child is learning that, oh my gosh, I'm not cold, wet, and hungry when I'm with that person who smells like stress and caffeine, then I want to be closer to that person. And I learn how to attach. I now can trust that this person is going to meet all of my needs. As that attachment grows, I learn that I can engage with other people. And this cycle continues where we go from a place of only receiving, only having our regulation externally regulated, to hopefully becoming adults that can both give and receive love and affection and attachment in a safe and healthy way. If we turn this same concept on its head a little bit, then we end up with a little bit of a trauma Christmas tree. If we look at a typical healthy human, we hope that we all are in this room, that our internal regulation is based on someone externally regulating us. And that now builds its way up to we are internally regulated, we can attach, we can engage, and then become the person that now externally regulates the next healthy human, right? That's the way it's supposed to work. And we all know that if that external regulation is not there, either from the very beginning in utero, very early infancy, or through childhood trauma, that we no longer have that internal regulation, attachment, and engagement, our potential for becoming the healthy human that we all want us to be goes away. And now the cycle breaks that the next healthy human does not arrive, which then leads to all of us having the jobs that we have now, right? So unfortunately, it is good job security for us, which none of us want. So what we look at when we're looking at internal regulation, the other name for that is interoception. Ception being the awareness, intero meaning inside. Our internal awareness, that still small, quiet voice that tells us when we're hungry, when our tummies are full, when we need to go to the bathroom, when we're irritated at our boss for an email that we got an hour ago, when we are feeling affection towards our spouse or another human in our home because the day went well. These are all small internal voices that we can all quickly do a scan without even thinking twice. Poor interoception, meaning we're not able to listen to that still quiet voice in our body, is we end up with a lot of emotional fragility. Inappropriate emotional responses. This is where we get big feelings in a little body that come out in big behaviors, right? The kiddo that just absolutely breaks over the simplest thing. Just tonight, I had a child in my home that stubbed their toe, and you would think the whole world had stopped spinning. So we had to walk our way through. We stubbed our toe. Are you okay? It sounds like you're mad. Tell me what you need. So that internal small voice got triggered. They weren't able to interpret that a small bonk didn't need to result in a big emotional meltdown. Poor eating and drinking patterns, kiddos that gorge aren't able to understand when their tummies are full, who won't have any hunger cues because they don't understand when they're hungry, don't know when they're thirsty. And this is where bedwetting and constipation come in. If we can't listen to that small voice in our bladder that tells us when it's full or when our bowels are full, then we end up with constipation. Interoception, you can have kind of two different levels, and it's hyposensitivity, meaning that you have a low awareness of your internal voice. So you're not aware of when you're hungry or thirsty. You're not aware of, or not appropriately aware of pain that you're feeling. This can also be uh, your own thirst and your hunger. When we are hypersensitive, we are more aware of things. So we have the constant aches. So that again, we're reading things inappropriately in our body. We're always hungry, even though you just saw this child down 12-piece nuggets and you know that they're not hungry, but they're telling you that you're hungry. Or they're always thirsty, or they can be really hyper aware of touch or textures. This is a hypersensitivity to interoception. If we break down interoception into steps and how we have to listen to our body, if we tell children not to touch hot stove, right? So a finger touches the stove and it feels a sensation. It feels heat. It goes through the nerve endings in the finger, up through the arm and into the brain. And our brain says, that is hot. We interpret the sensation. Based on the consequences, we now have to reverse chain our thought process. I have to plan a response to that sensation. So our brain tells us that's hot. Hot's going to hurt. It's going to burn. You are going to have a blister. I need to remove my finger from the heat source in order to stop this process. We then have to actually do it, have the thought, and then do it. And that sometimes is a multiple step process. Then we have to understand the outcome. I have stepped away from the heat. I have stopped the heat coming onto my finger. I'm no longer having a blister. Oh, I can actually have control over this entire process. And now I have to file that away for the next time I get close to the stove and someone says, don't stop, don't touch, excuse me. So there are multiple steps that our body has to understand what's happening when we come across some internal sensations. Now, if we break that down into listening to our bowel or our bladder, it gets a little bit more complicated. These are just the simple steps that we need to be able to go to the bathroom. It's intense, right? So we feel the bladder or bowel fullness. We'll just for a moment assume that this is either child who needs to sit on a toilet. So we feel the bladder or bile fullness, and then we have to interpret that information as, oh, it's full enough. I need to now empty it. Or the consequence, I'm going to have an accident, right? To avoid an accident and getting in trouble, I don't want that to happen. I don't want to have to clean up a mess. I don't want to have to change my pants. I have to stop what I'm doing. This is where it gets sticky for our kiddos that are having a preferred activity. I'm playing video games. I'm reading a book. I'm watching TV. I want to continue doing that. That activity is actually causing my serotonin to go up and making me feel good. I don't want that to stop. And now, this is if I'm at school, I have to notify an appropriate adult in order to make sure that I don't have that accident and then find the nearest bathroom, right? Once I get to the bathroom, I have to remove all of the appropriate clothing safely and independently. Depending on our motor skills, that may be difficult. I have to position myself onto a toilet safely and not fall off. That involves a lot of motor skills, gross motor skills. Then I have to identify the appropriate body part to relax that muscle and then allow the sphincter to open and empty the bowel and bladder, at the same time mitigating any sound or smell that may happen. We have all been in a public bathroom. We know that that's a bit of a dance that can happen and making sure that the next person in the stall has left before you take care of your business. When you are 7, 8, or 10, that can be really overwhelming. Then we have to be able to listen to our body and interpret when our bladder is actually empty or our bowel is empty, right? That can take a little bit of a negotiation. Once we have made that interpretation, then we have to balance ourselves appropriately to tip, but not fall off, to grab the appropriate amount of toilet paper. Now, that can be, no pun intended, a bit of a crapshoot, right? How much toilet paper do I actually need for whatever just happened? I can't see what happened, and I need to be able to interpret that information. And then I have to strategize. How am I a toilet paper wrapper? Am I a folder? Am I a buncher? How how do I make sure that I balance myself and hold this extra piece of material without falling over? And then blindly wipe appropriately without falling. Dismount the toilet safely, replace all the clothes safely and independently, and then go through what can be a sensory nightmare for a lot of kids to flush a toilet with the sound that it causes. Wash your hands, dry your hands appropriately, and get back to your previous activity and do all of this in a timely manner. This is a nightmare for kids who have executive functioning deficits related to trauma, who cannot follow more than 2 steps in any given routine. This can be wildly overwhelming. Just to make a point, this is what our brain has to do in order to listen to our bladder. And you can see that it gets really complicated really quick, from going the level of the muscle, the neurons inside of the top of the bladder that has to go to our spinal cord, and then up to our brain, and then all the chemicals that are in process just to make sure that we understand that it's time to empty our bladder. So it gets quite complicated. Proprioception is the opposite. So this is where knowing where your body is in space. This is the external awareness. So all of us are sitting on some sort of chair or couch, and we instinctively know that there's probably an inch or two, maybe 6 inches on either side of us, that if we move, we're going to fall. We don't have to put our hands out to understand that space awareness. Our brain can read that for us. We also know that when we go in for a hug, how much pressure we need in order to touch the other person without crushing the other person. That's proprioception. When we have poor proprioception, these are the kiddos that are always falling. They're bumping into people, they're dropping things, they have bruises everywhere. They're constantly seeking big body movements. They're jumping off the back of the couch, and they don't seem to have any awareness of safety at all. These are kids that don't know their own strength, that are going in for a pat and then leaving a bruise on somebody, and they're accidentally hurting everybody. Always touching, needing to be close. They're not aware of anybody's bubble. These are kiddos that have poor proprioception. They also tend to calm with really tight hugs or squeezes. This is where weighted blankets are really great for kiddos with proprioception issues. If you're super lucky, you're going to have a kid with poor proprioception, external awareness, and poor interoception, internal awareness. And that's a real treat. That is a special blessing in your home that really can require a lot of creativity in your parenting. So we aren't going to be talking a lot about proprioception tonight, but I do want to comment that there is the two, and they are different from each other. When we look at anatomy, the next slide for those who have littles with you will have the picture in it. When we look at the anatomy of the parts of the body that have to talk to each other, the urinary tract is relatively simple. Our kidneys are taking in waste from our bloodstream, processing it through a really complicated filter process inside the kidneys, goes down through the ureters on two sides, connects to the bladder. The bladder fills, even like the back of the toilet does. When it gets too full, then it notifies the brain. We release the sphincter in the urethra, and then we're able to urinate. The digestive system gets a little bit more complicated in we have food goes through the mouth, we go through our food tube, that's the esophagus, down to our stomach. The liver, gallbladder, and pancreas all have to squirt an appropriate amount of chemicals into the stomach to break down the food groups. From the stomach, we go into the small intestine. That's the squiggly part right in the middle there. And that breaks down the food even further. From the small intestine, we go over to the appendix, near the appendix to our ascending colon. This is the large intestine now. And this is where the muscles are automatically peristalsis moving the poop up the colon, adding water, making it the appropriate consistency in order to move it through the body. So we go up through the ascending colon, cross the transverse colon through the bottom of the stomach there, down through the descending colon, and then we take a little turn and go out through the rectum and the anus. Again, we have to identify that muscle to come out, and then we're able to poop. So it gets a little bit more complicated with the digestive system. Now, when we superimpose the urinary tract over the digestive system, we can see how closely that they are related and how they're tucked into each other. Excuse me. And when we look to the side views, we can see, hopefully you can see my cursor here, that you will see the colon and how close it is to the bladder. Meaning, if there is any backup in the colon, if we have constipation, we've got the traffic is backing up in the colon, we are going to be putting pressure on that bladder, and then we can have worsening of incontinence or bedwetting symptoms. You can see it again on the male side, how close it is to that colon pushing in on the bladder and how symptoms can be problematic. If we go from the bottom up view, you can see how close the muscles have to work together in order to make sure that we're relaxing the right set of muscles in order to either have a bowel movement or to urinate. So they're all very, very closely related, and that can cause problems that go back and forth with each other. When we look at typical toilet training, it's around 18 to 24 months when a lot of kiddos are beginning to show their interest in potty training. If you're bringing your kids into well child checks, it's usually around 2 years old that we start asking, hey, they're showing some interest. Are they following you into the bathroom? Are they starting to understand that when I'm wet, I need to be changed? So we're having that external awareness, external to internal, having that external awareness that I don't want to be wet or dirty. And mom helps change me so I'm clean. Dad helps change me so I'm clean, whatever the adult is that is taking care of the child. Then we start putting things together that, oh, just before I'm wet or dirty and I don't like that feeling, I have a release of the bladder or my bowels, and I'm actually the one making that mess, right? So now we have that internal awareness. Now it takes a little bit of a bridge. Girls tend to potty train between 2 and 3. Boys tend to potty train between 3 and 4. We start to have that internal control, external awareness, internal control. And usually by the time we're 4, most kids, I will say that this is a pre-COVID data for potty training for kiddos that are currently in the potty training era, preschool and kindergarten, seem to be a little bit later for whatever reason. Usually by 4, we're having most kids are daytime potty trained and bowel trained without any issue. And then it takes a couple more years for us to stay totally dry at night. But our first cue for that is if kiddos are staying dry during nap time or waking up dry in the morning, then this is a good time for us to really lean into potty training. If we think about the size of a bladder, the general formula is we take the child's age, 2, 3, 4, 6, whatever it is, we add 2, and that equals the fluid ounces in a normal bladder. So a 3-year-old, for example, has 6 fluid ounces that they can hold inside of the bladder. For a visual, if any of you have ever seen, I assume, a Capri Sun, That is 6 ounces. So that Capri Sun, that little square metal thing, is the size of a bladder of a 3-year-old. So imagine how long you can hold that 6 ounces before you're going to need to go to the bathroom. That developmental window of when kids are able to understand that interoception, listening to our bladder, our bowels, can change, is different for every child. And then when we throw trauma on top of that, that's when we have that delayed interoception. Maybe we have delayed motor skills. If there's a medical concern or a developmental disability, then this window shifts significantly longer. So now we have kiddos that maybe are not potty trained or fully dry at night until they're 7 to 9, even later. So that window just, we shifted over quite a bit when we've had significant trauma. Regression is not uncommon. So we will have kiddos that maybe at 18 months, you're like, I want to try this potty training thing on. They're really interested in the toilet. They maybe are totally dry for a week or two, and parents are like, shoo, let's get rid of those diapers. It's amazing. And then all of a sudden they regress and decide, yeah, we're good. Let's do diapers again for a while. Totally normal. A lot of kids will kind of flirt with potty training, if you will, and then regress back, but then catch up on their own without any issues. That regression can also happen with trauma. So we'll have kiddos that maybe have been in foster care or out of home care and have been really working hard with their caregiver on potty training. And then there's a big change in the case, whether it be visits have stopped or started, have gone from, monitored to in-home or overnights, and then all of a sudden we have a major regression. Happens quite often, and it's usually location change or expectations of the caregivers. So if we have kiddos that are in a foster home during the day, and then they go to daycare, and then maybe they're doing visits with family in the evenings, and they're going back to their caregiver home. And every adult in that spectrum has a different expectation of how we're going to navigate potty training. That can be really frustrating for a child and not knowing what to do. My general recommendation for foster families in that situation is just stop. Follow the bio parent's lead. If they are ready to engage in potty training, especially if we think reunification is going to be likely, then just follow their lead. Your child will not go to prom in diapers. They will potty train. It will be okay. But in as much as you're able to have a conversation with all the adults in a child's life, that does help with some consistency. I will say that a lot of parents tend to rely on daycares to be the primary potty trainers. There is an upside to that. Taking a child to the bathroom every 10 or 15 minutes throughout the day takes a lot of dedication that sometimes can't be done well in a home when you're balancing working and multiple kids and making sure a kiddo gets to the bathroom. It's a little bit easier to register that in a daycare day. So again, that's just a conversation to have with everybody that's in that kiddo's life. The risks of bedwetting specifically, there can be a pretty significant family history, and I think it's funny that the statistics are so wide. So anywhere between 15 to 75%, that's a really big spectrum. Higher if one or both bio parents were bedwetters. So if mom, was a bedwetter until she was 5 or 7, and dad maybe was a bedwetter until he was 12, then we kind of need to plan ahead for that that's likely going to be this child's story. Then there's genetics. If, grandpa had a really tiny bladder and, needed to come back from farming every 20 minutes to go to the bathroom, and then dad had, a really small bladder and he could never do a road trip because he needed to pee every 20 minutes, Johnny's probably going to have a small bladder. So that's something to think of, that there may not actually be anything wrong, that this is just the world's smallest bladder just because of genetics. Delayed maturation or maturity of the bladder can certainly happen. This can be related to chronic bladder infections. This can be related to medications. So that's something to consider. Sleep disorders can be a really big part of this story. And this is where if I have a kiddo that is a deep, deep sleeper, or if they're a really bad snorer, if there's any concern for apnea, I have been always surprised at the number of bedwetters that have been totally healed or resolved once we take their tonsils out. And the tonsil bone's not connected to the bladder bone, but it tends to work really well that if we can get this kiddo breathing well at night, now they are able to listen to that interoception in the middle of the night, that the bedwetting tends to resolve itself. Trauma and abuse history. Um, so certainly we think of sexual trauma. If that has been an issue, if a child has been neglected or berated because of bedwetting, and this is continued, if a child's not ever able to fully fall asleep in the horizontal position, we can't let our bodies fully relax at night to be able to sleep, then we're not letting the rest of our body speak to us either. So that can be a significant part. And when a child is finally feeling safe in an environment, we tend to see bedwetting get significantly improved. There is always the component that this is behavioral and or oppositional. We're going to talk about that at the end, and I will warn you, I don't have an easy fix for this. I have certainly have had cases where, Johnny, it's time to go to the bathroom. I'm not going to. I'm going to go to bed, and 10 minutes into being in bed, will intentionally urinate. So there are certainly kiddos that have this, and that's something to take into consideration. And if we think about the picture that I showed you just a few slides ago, constipation is actually one of the major risk factors to bedwetting because of how close everything is. Again, if there's a colon full of stool that's pushing up against that bladder, we're going to have significant issues in the nighttime. So all children with chronic bladder complaints have constipation until proven otherwise. So hopefully when you're talking to your provider about bedwetting, that is actually a question that they're asking. For traditional bedwetting care, meaning non-trauma aware bedwetting, the process is pushing the extra fluids during the day. So we're actually stretching that bladder to the point where you have to respond to it, even threatening, an accident during the day. But we're teaching the body to actually listen to a stretched bladder so they understand an overstretched bladder. So they understand what that feeling they're supposed to interpret at bedtime. And then we cut off all the fluids after dinner time. So we're deflating that bladder. So we don't have any accidents in the middle of the night. We do ask that the child use the restroom immediately before going to bed. So we put our pajamas on, we read our book, we brush our teeth, we get our favorite stuffy, go to the bathroom, and then climb into bed. So we have that bladder completely deflated as far as we can before we go to sleep. And then adults waking a child in the middle of the night. So as the body is continuing to process whatever fluids are in the system and that bladder is starting to fill, that we can again deflate it before we hit that really, really deep REM sleep that usually happens between 2 and 3 in the morning. Bedwetting alarms are one of the first things that are discussed when we talk to a urologist. Um, I don't like bedwetting alarms. And I'm sure my urologist friends are probably going to kick me for this. But with kids with trauma, I don't want their cortisol, their stress hormone, or their adrenaline to be raised at all when they are sleeping. I need sleep to be a safe, peaceful, restorative time where they can be horizontal, they can be fully checked out, and their body can be safe. If we are jolting them awake in the middle of the night with an alarm, with vibrations, with a shock even, there are some that can be literally shock you awake. We are teaching the body to never fully relax, and we're reintroducing that trauma every single night. So I do not recommend bedwetting alarms for kiddos with trauma. And certainly sticker charts and motivators for our younger ones to be able to, hey, you're dry. That's so exciting. Let's do a sticker. Or we're gonna buy this new favorite truck or toy. If we can stay dry for 3 nights, that's a big part of the traditional process of treating bedwetting. Tricks for us in the trauma world is if we're able to identify the trauma, if we know that there was sexual abuse that happened, if we know that there was nighttime issues, we were locked into a room at night, we weren't able, maybe there was no plumbing in the house, if we were in a truck or trailer, we were in the car, we were in an RV, whatever the case is. If we're able to identify what that trauma is and then start to reverse it, that's going to be our first goal. Second goal is to keep a schedule. Our bedtime is safe. This is that we do the same thing every single night. We have the same routine. We have even the same pajamas, the same people putting us to bed. Nighttime becomes a safe place for this child where they can anticipate how bedtime is going to go every single day, no matter what. Even if you're on a trip, if you're going to a hotel, whatever the case is, we're following the same bedtime. We're making that as a mundane and safe process as possible to teach the body to relax and to be able to listen, engage that interoception, so we know when our bodies are full and need to get up and go to the bathroom. We do actually continue to push those fluids during the day. We want to teach the body to listen and be aware of the bladder. We limit the fluids before bedtime if it's appropriate. And I add this because there are some kiddos that come from a lot of food insecurity or they didn't have the nurturing at night that they needed. Someone who was responding to their call, maybe using the cried out method for kiddos, or a lot of neglect where nobody came to them when they were upset at night. And they use a water bottle at night as their own personal pacifier. So if they need to have that water bottle at the side of the bed, please do not take that away from them. I would much rather for a child to wet the bed, and we'll deal with that for a little bit longer, than to take away how they have learned to self-soothe, because that's ultimately going to do more trauma if we take that away. If it is safe to do so, it kind of has to be negotiated with the information that we have about the child. Go ahead and wake the child when the adults go to bed. So when the adults are going to bed at 10 o'clock, 11 o'clock, whatever it is, and we don't think that this child is going to be, traumatized by being woken up, go ahead and wake them up gently and take them to the bathroom. If we have any indication that there has been nighttime trauma, that they're going to jolt awake and this is going to be a scary process to wake them up, please don't. Let them sleep, let them restore, let them heal at night, let their bodies relax, and don't wake them up. But I would have you get up 10 minutes earlier and in the morning and go ahead and wake them up then. 10 minutes on your day is not going to be particularly traumatic. And if we can get them into the bathroom before the bladder is totally full in that first morning pee that we all have, that first morning kind of big release, if we can catch them before that happens when they're in bed, then hopefully we can again train their body to understand I'm over full, or I can wake up just before this happens, and we can break that cycle. Avoiding the bed alarm is going to be best. We want to refer to our friends at occupational therapy sooner rather than later so we can really focus on that interoception, listening to the body. And then plastic sheet lasagna. That is my own special term because I've needed to use it in my own home with kiddos that have struggled with this in my house. So essentially, mattress, and then bed mat, plastic sheet, bed mat, regular sheet, bed mat. And we're just going to lasagna that up so we can protect the mattress, quite frankly. But then we really have layers of protection. So we have some point where, oh my gosh, look at that. There was some dryness here. So if we can find the wind in not having the urine go all the way through the bed and not having to change multiple layers every single night, we're going to start to see some success. Go ahead and use pull-ups. And it doesn't matter the age. I recently had a 15-year-old that needed to use pull-ups at night. That's okay. We can do this discreetly. You don't have to use them during the day. Go ahead and use it if that's going to help the sheets stay dry, the child have lack of embarrassment, if we because have everything to contained. Go ahead and use the pull-ups. Don't worry about that. We will talk about what insurance covers later. Focus on safe relationship, right? And this is kind of being aware of our own triggers. If it's just driving you absolutely bonkers to have to change sheets every single morning, excuse me, sheets can't be the thing that break up this relationship. So we really do need to have adult plus child equal healthy relationship. And if we have adult plus child plus wet sheets are breaking this apart, then we need to do whatever it is to make sure that the sheets stay dry. And if that means the pull-ups are going to be it, if we need to do plastic sheet lasagna, or resetting our own expectations that we are going to be in the bedwetting land for quite a bit, then really focus on that relationship so it doesn't ruin things. And as weird as this sounds, wait for puberty. This works. There is the input of sensation to all the appropriate areas, and interoception just goes through the roof during puberty. And there tends to be kind of a switch that gets flipped when a child finally goes, oh, That's the part of my body I'm supposed to be listening to. We tend to see this more with boys than girls. Just saying. That we, yes, that is the part of your body. What you're feeling right now? Yes, that is where you need to be paying attention to, especially at night. So puberty, I've seen this happen in more than a handful of kids where it just finally clicks, that they can listen to their body. When to refer. So this is outside of getting occupational therapy on your team pretty quick. If we know that there's sexual trauma, we do want to have a forensics team or even our urologist to make sure that we don't have any uh, anatomical damage. So that is something to consider pretty darn quick. If there is a history of delayed walking, it may lead to, excuse me, it may be related to some spinal issues. That is significant. We're going to need to get a hold of that right away. You may not know that, but again, if we're having some bedwetting issues, that may be a question to ask your social worker sooner rather than later. If bedwetting persists into middle school, there is medication that we can use from the urologist. It's called DDAVP. It works on a very specific part of the brain to help to mitigate bedwetting. The problem with it is that it can impact your sodium levels, and we have to do blood work on a pretty regular basis. So I'm not a big fan of using it for kiddos that have been through trauma. Although if they're old enough and can navigate pokes, that may be a real option. If we have new bedwetting after significant length of dryness at night, that may be an indication of an infection, and we need to get that taken care of, or new trauma that we should be aware of. And if we're starting to have new daytime accidents, that is something that I get concerned about for a possible infection. And again, your child will not go to prom in diapers. This is not going to be long term. They will make it. I know it's so frustrating in when you're in the depths of changing sheets every morning, but they are not going to go to prom in diapers, I promise. So, poop. Let's talk about it. Everybody's favorite topic, right? So, the primary thing with pooping is that the goal is to eliminate waste, the stuff that we don't need. So, really, every day is not necessary. We don't have to poop every day. We do regularly want to make sure that we do have a schedule. It tends to be about every other day. For some people, it is every third day, but we are looking about 4 times a week that we do need to have a good stool moving our bowels. The goal is to have a soft stool on a regular pattern. So we're not going every 2 days and then waiting a week and then every day. We do need to have a regular pattern that is somewhat and can be anticipated. And we want to make sure that there's no straining or blocking of the toilet. So if we're having a soft stool every 4 days, but it's big enough that we're blocking the toilet, that's not what we need. So we need to change or probably intervene on things. And it is important to understand that poop is 75% water. So if we have kiddos that are dehydrated, we're not going to be pooping. This is, if you've ever been to a gastroenterologist, this is the favorite picture that all of my GI friends like to talk about. This is called a Bristol chart, and this is rating the type of poops, the type of stools that we have or not supposed to have. So our goal is to have those type 3, 4, or 5. I would encourage you to kind of do a self exam over the next couple of days and just kind of rate, are you hydrated enough? Are you having the right kind of poops? If we are having rabbit stools, that is rabbit poops, that is type 1. If we're having kind of those hard to pass, real lumpy, sausage shaped, tends to be a little bit shorter, that's type 2. 3, 4, and 5 were a little bit looser, softer, still has form, but tends to be soft. When we get into 6 and 7, we've lost our identity as poop, and now we're just fluffy and mushy. And type 7 is that straight up post Taco Bell poop, right? Like we've all been there, and that's not what we want on a regular basis. If it's related to an acute illness, certainly we can expect it, but um, we don't want that type of poop on a regular basis. And just for my own personal entertainment, if anybody catches the joke on this screen, that is indeed a royal flush in a deck of cards. The risk of constipation is going to be a poor diet. A lot of our kids come from that. We need both fiber and water in order to make sure that poop gets pushed through with that peristalsis, that automatic muscle movement that happens in the stool. Chronic dehydration is a real issue, and that's the primary issue with our kiddos with chronic constipation. Low activity and exercise. And this is not just our video game playing boys that are sitting around. These are our book reading girls as well. If we're not up and moving, we cannot get those muscles engaged in the lining of the bowels or around the bowels to push things through. Trauma and abuse history, certainly, sexual abuse can make this happen. We've had kiddos that maybe were not supported in their potty training or poop training, that were shamed because of having accidents or having stools, needing help when they were little to have their bums wiped. That can all be related to withholding and not allowing poop to go through. We can't control the movement of the bowel itself, but we can control the sphincter, that tight squeeze that we can have, and we can learn to actually not allow that sphincter to release, and then we withhold the stool. Medication side effects is a massive one. If you have a child on guanfacine, and it's probably the number one medication that I prescribe, the number one side effect is constipation. If you've been in my clinic, we've talked about that. If your provider has not talked about that as a side effect, make sure that you ask about it. So if I have a kiddo that's starting to struggle with constipation that hadn't struggled before, my number one concern is going to be a medication side effect. And this also includes supplement side effects. So if you're using some extra vitamins and things, that's something to look into. There are thyroid and inflammatory issues that can happen. We tend to not see this in kids. This tends to be probably older teenagers, adolescents, young adults, and into adulthood. Tends to be more with women because of the thyroid. Occasionally we can have it with boys, but it tends to be adolescent or young women that has the thyroid problems. And then we get to the point with potty training or toilet training where adults don't know how often kids are pooping. We just kind of leave it on their own. So we just don't know. And that can lead to more issues of constipation if we're not doing kind of the normal check-in. Hey, did you poop today? When we have that persistent stool in the rectum and it starts to back up, we can actually get some leakage of, excuse me, fecal material around the anus, so on the outside of the body, that leads to a colonization of bacteria, specifically E. coli, which is the bacteria in poop, which can lead to chronic bladder infections, especially for little girls, because all of the anatomy is so close. Again, you can reference that picture. And one of the things that we, as the safe adults in these kiddos' lives, is really be paying attention to behavior changes, especially for our preschoolers and our elementary school kids. And if they've gotten cranky fast the last couple of days or starting to have behavior changes at school, one of my first questions is, how are we pooping? Which is kind of the classic nurse question, right? But it really is one of the big things that are going to impact behavior for that age group. When we look at tips and tricks for constipation, normalize pooping. Talk about it in your home like you talk about brushing your teeth, right? How was school today? Did you brush your teeth? Did you poop? Right? If we just are having normal conversations about a normal bodily function, I think it's going to open up conversation that's going to be a little bit easier to talk about. Gosh, what was your poop style today? Right? And talk about it as adults. I'm not saying that you have to get gross. You don't have to have potty talk at the table, but just having normal conversation of, oh my gosh, I had Taco Bell and my tummy did not like that. I was so scared I was going to have an accident at work today, right? Just talk about pooping and passing gas, farts, whatever the term is in your home, and being able to normalize it because we all poop, right? There is a book about it. Making sure that we're keeping active. So we have bodies that are constantly moving. So we're stimulating those muscles in our body that we need to make sure that we're pooping. Moving before we actually go to the bathroom is important. Doing 10 jumping jacks, doing a couple of sit-ups for our real active boys, get things moving before we sit on the toilet is going to be quite helpful. Water, 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 and more water. Poop is 75% water. And if we're not giving our bodies water, it can't draw that water into the lining of the bowels to be able to push things through. And then we end up with that dry, crusty rabbit turd. like stools. Prunes and mangoes are your friend. Now, young kids don't know that prunes are gross. We all know that prunes are gross, but young kids don't know that. So go ahead and introduce it into the diet, whether it's actually eating prunes like raisins or using prune juice. You can actually mix prune juice and apple juice. That tends to be a good cocktail for some kids. Mangoes are a great alternative, full of water, full of fiber, full of sweetness, a little bit easier to get things down. You can do a puree, you can add it to a smoothie, you can just eat mangoes plain. It's a great way to get things moving. Keeping a schedule. A lot of kids are scared to use an unfamiliar toilet. So knowing that, gosh, we're going to be, headed to school. Why don't you go ahead and go to the bathroom before we go? When we get home from school, that's a good time that we can poop. Um, if we're doing visits and we're going to be, out in the community, we don't know where the toilet is, making sure that we can navigate that as much as we can by keeping a schedule. And if you're up for it, go ahead and Google Bristol poop chart, stool chart, and post that in the bathroom or in a place that is reasonable for the child so they can kind of monitor and keep track of their own stools. Now, there is, an age and a personality that's going to be more into this than others, but that may be an option for your home. Keeping a poop diary. I tend to do this for a lot of my young ladies who would not even dare to admit that they poop. Then have them write it down, whether it's in their phone or on their tablet or having their own little poop diary, so they can keep track of how often are they actually pooping, is going to be important for us to get the right information to help keep them healthy if we need to intervene. Having bathroom spray. If we can mitigate the smell, right? That's part of getting rid of waste in our body. If we have that readily available in the bathroom so they can take control of that process. Taking a bath with Epsom salts. Epsom is a natural magnesium. Magnesium is a natural muscle relaxant. We're going to talk about medications here in a minute, but for our little ones that are constipated, taking a bath in the evening with Epsom salts can be quite helpful. Making sure that occupational therapy is a part of your team earlier rather than later. I will say in King County and Pierce County, getting into occupational therapy right now is very difficult, months long wait. So if you have any concerns, you and your provider refer now, so we can get that child in. And then we're going to go back to external regulation. So a vibrating neck roll. Stay with me here. So and I'm going to show a picture of this later, but a neck roll that goes around your neck that vibrates, feels good on your muscles, right? Put that around the abdomen when a child is sitting on the toilet. Turn it on. Now we're putting that external stimulation on the area of the body that they need to be listening to when they're pooping. This is a great way to teach a child, oh, that's the part of my body that I need to be listening to. Now, it's not appropriate to actually put anything near or on the anus, but that's the part of the body we need to relax. But if we can put it around the abdomen and teach that child that, oh gosh, this is the part I need to be listening to, it's really quite helpful. I have used that strategy with a good number of children, and I'm thinking of a 12-year-old that was still struggling with bedwetting and constipation, really could not figure out how to get his body to respond. And we introduced the vibrating neck roll, and within 3 weeks, both issues were totally resolved. He just needed his body to be able to understand where to listen. So it really works well. A toilet stool, if we can get our knees up a little bit higher, it actually tilts the pelvis back. It puts the pressure on the sphincter, the pelvic muscles around the sphincter, allows you to focus on that specific area, allows pooping to happen a little bit easier. Using baby wipes instead of toilet paper, not flushable wipes. They are not flushable, but good old-fashioned baby wipes. And if what it does is get that sensory input when that baby wipe touches the part of the body that it needs to touch. I'm feeling something wet. Dry paper on your bum when you're trying to wipe something that you can't see can get really complicated. Like you have no sensory input to tell you if you've even hit the right spot. But a wet baby wipe, you now have that extra input that will tell your brain that yes, you've hit the right spot, and you can get a little bit more coverage and be able to get clean. A bidet can be helpful. And you don't have to have a separate toilet. There are bidet attachments that you can use, and actually using the bidet before there's pooping to actually a little stream of water to the part of the body that needs to be relaxed, and then being able to poop, use the bidet again to clean up. That can be quite helpful. I would talk to your social worker and make sure that everybody is aware that this is being used. You might need to get special approval for that. Now, when we go into medications, excuse me, fiber. So fiber helps absorb water into the bowel. So it brings it outside of the bowels, inside of the bowels, and it makes the stool bulkier and softer. So hopefully to pass it through. Basically, the weight of the stool is now being able to push through. The problem with lots of extra fiber is that bulk can actually cause a blockage. And now we're backed up into the bowel and nothing is passing through. So we tend to not use a lot of extra fiber in kids, Metamucil, Citracel, that may be something that your parents use or your uncle, your aunt, whatever. But we tend to not use that with kids. But using prunes, mangoes, food-based fiber, vegetables, right? Our kiddos that just won't eat a vegetable to save their life. If we can introduce more of those vegetables so we can get that fiber just naturally through food, that can help quite a bit. Miralax is actually the primary treatment medically for constipation. All of the research right now is based on Miralax. This increases the water in the bowels and tends to work within 6 to 8 hours. For kiddos that have had severe and chronic constipation, it can take longer. I've had some kids that it's 24 hours and things aren't moving yet. The problem with the Miralax working that fast is that we can have cramping and diarrhea, and that can be a real negative experience for kids where they don't want to use it again. And interestingly, even though it's the number one treatment for constipation in kids, it's not actually FDA approved for kids. We are using it off label. And there has been some anecdotal data on maybe chronic Miralax use causing some behavior changes. We don't have hard data on that yet, but there's enough anecdotal data and I think enough like scuttlebutt online that parents tend to be hesitant to use Miralax long term. And that's, reasonable. We can honor that. Laxatives, there's different kinds. There's stimulant and osmotic laxative. The stimulant laxatives irritates the lining of the bowel. So think of like tickling the lining of the bowels to kind of push things through. Tends to work pretty quick, but because it's working quickly, we can get that abdominal cramping. And this is where there can be quite a bit of abuse potential because we're passing stool quickly. We tend to have a weight loss associated with it. So I am hesitant to recommend laxatives, especially for our adolescents that may have some body image issues. They are used well after surgeries or if there's going to be medication specifically prescribed that we know can cause constipation. Magnesium is the one that I tend to recommend as kind of a daily preventative. There are several different kinds of magnesium, and this is actually the number one question that I get about magnesium. If you are using natural calm powders or gummies in your home, that is magnesium citrate. Milk of magnesia is magnesium hydroxide. Epsom salts is magnesium sulfite. And then the sprays that you can use is magnesium chloride. So they're all processed a little bit different in the body. All of them can help with constipation. I think the easiest one for most of us that have easy access to is citrate. This is one where if it's not working, we're not going to do more just to force it to work. It's hard to overdose on magnesium, but there is always a chance. And then if we're overusing it, we can get diarrhea. So that can be problematic. Stool softeners work a little bit differently. They actually pull fat into the stool, so we make it nice and slippery to help it go through the bowels. It is slower to work. If I have, again, people that are on specific medications, iron being one of them, we have some anemia. I'm prescribing iron. I automatically give Colace because I don't need it to work right now. I'm just trying to prevent something from happening. That can be an option. Or if any of you are of a generation where your parents or your grandparents gave you mineral oil or castor oil every day, just open up and you took your spoonful, that was actually lubricating the lining of the bowels, works pretty quickly. We don't give it to kids under 6. It tends to not work as well, and honestly, it tastes gross when we give it to other kids. And we don't want to mix it with any other remedies. So this one tends to not be one that we use very often. Our friends in gastroenterology will use it in combination with things, especially as a colonoscopy prep. but not one that we use on a regular basis. And then lactulose or sorbitol is actually in a lot of our processed foods, including baby formula. It is a non-absorbable sugar and it actually ferments in the bowels, makes everything gross, and then is forces the bowel movement. We have it in a lot of our processed foods. If any of you drink like the no sugar or zero calorie drinks, if you look at it, you're going to see sucralose, lactulose, any of these fake sugars. If you have a particularly sensitive system, drinking one of the ice drinks, sparkling ice drinks, can cause some diarrhea, and it's because of that non-absorbable sugar. For the sake of foster care, I'm just not going to recommend or even review suppositories or enemas. That's just not something that we need to be doing for our kids, especially if they're over the age of 3. So when do we refer for constipation? If we know that there's sexual trauma, that's something that I want to have our gastroenterologist or even our sexual assault center to be aware of. We just need to make sure that there isn't any anatomical damage. If we have bleeding with stools, meaning that the stool comes out and there's bleeding around it, dripping into the toilet, or if there's blood in the stool, kind of wrapped into the stool itself, that can tell us that there's bleeding at different levels of the colon, and that's something that we need to be aware of. If there's really abnormal vomiting, specifically if it looks like coffee grounds or smells like poop, that means that the stool has backed up into the small intestine, that real squiggly part, and is now pushing up into the stomach. And that is a level of constipation that I don't know that I would wish on my worst enemy. So that is something we need to know about right away. It can be indicative of a pretty significant blockage. If we're having new abdominal pain, kind of above and beyond our typical constipation pain, or if we haven't had a stool for 7 full days, or no stool for 3 weeks while we're getting intensive medication treatment, right? So when we're on a regimen, if we're using Marilax, we're using magnesium, we're using different things, and we're still not stooling on a regular basis after 3 weeks, then we need to have our friends in gastroenterology help us out. Unexplained weight loss when we've got constipation or constipation with a fever. Those are indicative of other issues, and we need to get those addressed pretty quickly. Mary Bridge here in Pierce County did have a toileting clinic, which was a gastroenterologist, a developmental pediatrician, and an occupational therapist that would all meet with a family together and come up with a plan of care. They were doing it on a regular basis, then it was only once a month and then once a quarter. I have not been able to get hold of them in several months, so I don't know that it is being used anymore. I did confirm that Seattle Children's does have their bowel and bladder clinic, and that is still active. So if you were in the area, or if we feel like we need to have further kind of a team-based approach, we can refer to Seattle Children's. Now, this is the one that it's usually the primary question that I get with the kiddos, the hiders. They're hiding their pull-ups, they're hiding their dirty underwear, or the artists, even. We got our fecal artists. They're just all Jackson Pollock all over the walls. I don't have an easy answer for you, but I want to acknowledge that this happens. It's very, very hard. It takes a lot of creativity and strategy by multiple people in a child's life. And it tends to come from three kind of major pillars of concern, shame being the big one. I'm scared that this happened. I had no control. I didn't mean it. I don't want to get caught. I don't want to get in trouble. There's the control component, and that's for our oppositional friends. It happens. And then we've got our sensory processing kiddos, and this tends to be the ones with maybe a dual diagnosis with autism or other developmental delays. So focus on safe relationship. Again, you plus child needs to equal healthy relationship. If it's you plus child and dirty underwear equaling unhealthy relationship, then the only thing that can be jettisoned out of that equation is the dirty underwear. I did actually have a family who the caregiver was so triggered by dirty underwear that they had a displacement. And ultimately, the plan that we came up with, if this dirty underwear is going to be the thing that breaks this relationship, we went to the state and we said, we need an unlimited amount of underwear that this child can have as much underwear as they want at any time, and this family can be well supported. And that's what worked for this family. So we did have to go to the state for that. Normalizing bodily functions. Hey, everybody poops. People have accidents. It happens. Go ahead and talk about sharding. We've all, like, we're all human and it's all happened. So being able to talk openly about that, narrate it through the day. Gosh, I was at work. I didn't think I was going to make it to the bathroom, or I had a little accident. I had to call home, and my wife, my partner, whoever had to bring me a spare pair of underwear. I thought I was going to be sick because I had Taco Bell yesterday. I brought a pair of spare underwear with me in my bag. I was so glad I had it. Whatever you need to do to kind of normalize that this does happen, hopefully will decrease the shame that is related to our friends who like to hide their events. If you can, kind of monitor the timing if you're noticing that this is happening in the afternoon after school, if this is happening after weekend visits with bio family. If there's some sort of trigger that you can kind of put together, then that will help you intervene at the right time. If it's happening after school, there is the potential here that this child doesn't have a safe place to go to the bathroom at school, and they've waited all day long. They just kept it together and then had the accident when they came home. So that 8 hours of holding that bladder, that bowel, and they haven't been able to get to it. So if it's pretty regularly at a specific time, we can backtrack and see if we can find an intervention there. And then let's just frankly eliminate the need to hide. We're not going to shame, we're not going to punish, we're not going to argue with the fact that we're hiding. Like, I know you're hiding, you know you're hiding it. Like, we know this is happening. We're not going to argue that fact because it's just a fact, right? So redefine the problem is we need to have a new place for the hiding to take place. So we're just frankly, hey, Johnny, I'm putting a special garbage can in your closet so you can just put all of your underwear or your pull-ups there. Okay? Susie, hey, in the morning, you and I can take the sheets off your bed and then we'll take them to the wash together. Like, we're just going to call it what it is, and we're going to provide a solution that we can do together. So we're focusing back in on that relationship. The problem is that that takes time, right? And this tends to happen first thing in the morning when we're trying to gather everybody together to get to school, out the door, let's go. And can be very difficult to have that extra time to be able to engage that way. So it is going to take some parental effort. I've needed to do this in my own home. We do not have cats in our home, but by golly, I had a room that smelled like cats and was sniffed it out, and there was a week's worth of wet pull-ups in a room. So, hey, Susie, come on in. I'm going to show you. We're going to gather these up together. I'm going to show you where you can put them, and then we're going to do this again tomorrow. And we're just every day, I'm going to come in and help you, and we're going to do this together. And if we can normalize the process that the bedwetting, the poop accidents, whatever it is happening, but our problem is that we don't have a place to put the pull up, the underwear, the whatever it is, and you're going to join in the solution for that. Give control when and where you're able to do so. If this is a kiddo, no matter the age, that needs to learn how to do laundry on their own, that they can have control, that in the middle of the night, if in the morning when they've had an accident, that they can just grab everything and do the laundry on their own, great. If they need to have their own separate garbage can or their laundry basket, great. If they need to, if it's possible to have access to their own bathroom, great. So when and where you are able to give that control, go ahead and do that. For our more obstinate kiddos, BRS can be helpful. Come up with a different plan. Attempt to avoid consequences. If this happens again, you're not going to have access to your switch. If I find this again under your bed, then X is going to happen. This is only going to feed into the shame and a kiddo's need to manipulate your response if they are on the obstinate side. So, positive reinforcements are going to outweigh the consequences at this point. For our kiddos that are on the spectrum, the fecal artists, they're really excited about the organic nature of their body. If we can find the timing of that, tends to be, during nap time, tends to be when they're been quiet too long. And if we can provide an alternative sensory input, the timing, being able to get to the pull-up or the diaper or the underwear before they can, it's going to take a lot of work on your side. And then providing some extra sensory input. And that's where your occupational therapist is going to be able to help quite a bit. It is going to take patience. I wish, again, I had a way to say, here's the magic trick to make this all stop. I just don't have it for you. It's going to take time. Supplies. This is the neck massager I was talking about. I do not have any investment in this. This is just the one that I worked with. It works really well. That blue lining on the outside actually takes, you can take it off, you can wash it. Works really well. It's very malleable, it's very soft. I put a link in the slides, which you'll get later if you want to go straight to Amazon and get it. Good Night's brand. I think Walmart has their own brand, disposable bed mats. So if you're traveling, if you're going to a hotel, if you're going to be doing overnight somewhere, these bed mats, the experience that I've had actually work better than the washable bed mats. They tend to be a little bit more absorbable. They're easy to just put down on the bed, get it off in the morning, no problems whatsoever. I have used these for kiddos that have been with me where we've been on overnights and we're just, okay, we're going to put this on the hotel bed and that one's yours and clean it up in the morning and here we go. And then this is an example of a pooping stool that can work quite easily. Different colors depending on the toilet or the brand or the aesthetic of your bathroom if you need it to fit in well. Insurance, assuming that your child is in foster care and they have coordinated care coverage, they will cover durable medical equipment that includes diapers, pull-ups, washable bed pads, gloves, and wipes for kiddos over the age of 3 that can be delivered to your home. So I'm surprised at how many families don't know about this when we talk about a 5-year-old that's still having issues. You don't need to be paying out of pocket. This is something that insurance will pay for. If you were talking to your provider about it, there are diagnosis codes that they need to use, and incontinence, whether it's fecal or urinary, and you can actually use the code for child in foster care. I've gotten a little bit of kickback from one of the DME providers here in Pierce County that they were no longer, that incontinence was no longer covered. Bedwetting was not a covered diagnosis. I talked to coordinated care this week, and they don't understand why that was being denied, but they said they are willing to process any prior authorization if you're getting any kickback from a specific pharmacy or DME provider. So don't pay out of pocket. There is coverage available. For references and resources, these two articles are actually based out of an occupational therapy continuing education site. It's absolutely fantastic. Highly recommend. AAP and the Gastroenterology Association also have great resources, and there are links to that vibrating neck roll and to the toilet stool if you would like to access that. And that brings us to the end, an hour some odd later. So, what kind of questions